Welcome back and thank you for staying with Morning Prime. Of course, we continue with the gender issues and we're talking about infertility. It is Infertility Awareness Month. And joining me right now is Dr. Kireki Omanwa, who is the president of the Kenya Obstetrical Gynecological Society and equally a fertility expert at Frontline Medical Consultants. Good morning.
Thank you very much. Good morning, Ashley.
Thank you for making time. It's always a pleasure having you. So, of course, it is Infertility Awareness Month. And when you talk about infertility, of course, we know what infertility is, but there's so much to it. Maybe we can start with the basics.
Yes.
What leads to infertility?
Thank you very much. First of all, thank you so much for welcoming me to the studio. And this is a very important topic. It is a topic which unfortunately touches very many people. If you look at statistics, for example, in the developed world, infertility affects about 8 to 9%, even if you were to say 10%, about 10%. In this part of the world, it affects about 20, sometimes even up to 30%, depending on who you are looking at, which researcher you are looking at. Now, just to give you a rough idea, if we say that the Kenyan population is about 50 million, give or take, and we say that let's work with 20% of the Kenyan, of that number, 10% is 5 million, so 20% will be about 10 million. So it's a huge number. Yeah. Even if you work with 15%, which comes to about maybe about 7.5 million people, very large number. Nairobi has about 3, maybe 4 million people. So it would mean everybody who lives in Nairobi. And then you throw in a few other counties, surrounding counties, maybe Kiambu, maybe Kajiado, and so on, Machakos, such that all those people who are living in those counties are all affected with infertility.
And these are just women or men equally?
Men and women. Okay. Men and women. Now, you asked about what causes it. Maybe before we go into what causes it, maybe you'd like to define what it is, first of all. According to the World Health Organization, there are actually 2 aspects of infertility. The first one is what we call primary infertility, which basically means that a couple, which is a man and a woman, have been cohabiting, have been having regular intercourse, and regular means 2 to 3 times a week, because sometimes you may have once a week or once a month or once every so often. That is not regular. Okay. So 2 to 3 times a week, and a time period of about 1 year has passed, and none of them using contraceptives. So no condoms, no oral contraceptive pills, etc. And there has been no conception, no baby. There is a caveat to that definition, and that caveat is age of the lady. Okay. So if the lady is 35 years and above, that 1 year is shortened to 6 months. So, and then there is secondary infertility. Okay. Again, the same principles apply, whereby there is regular intercourse, 1 year has passed, and there is no further conception, meaning this couple have had a baby, or they have children, or have had a conception in the past, so they are trying to get another conception, and it is not happening. And then the other caveat to this, the secondary infertility, is that the lady is not breastfeeding, because breastfeeding, regular breastfeeding, can actually act like contraception.
Oh, really?
Yes.
Okay, that's something I didn't know. But of course, you talked about primary and secondary.
Secondary infertility, yes.
Of course, we have instances where we're seeing couples try for a few years before they finally get children. Does that still classify under infertility?
Yes, it is still infertility. It is still infertility. They've tried for several years, it hasn't worked. So that's 1 year, or those 6 months, as I said, is just the minimum. There are some who try for 5 years, for 10 years. I see patients who have couples who have tried for 18 years, and so on.
Okay. Yes. So then, of course, at what point do people know, okay, now I need to go see a doctor, or now I need to go see, someone who can help with the situation?
Number one, that you fulfill those conditions, that you've been having regular intercourse, and that time frame has passed, and there is nothing that you're doing, there's nothing that you're using, which consciously is going to stop one from getting pregnant. You're not using contraception, any contraception. So if that time frame has passed, you're not using any of those, it is time to go and visit a fertility specialist.
So then what happens once they get to you?
Now, once they get to me, there are several things that I want to do. Maybe I can put that in the parking lot for 2 seconds, because maybe we can generally look at what are the possible causes of infertility. And then we can come now to that. Once they come, what we need to do or what I'm going to do with them. So if we are going to look at the causes of infertility, we can actually look at them in two ways, or two groups for that matter. There are the causes which affect women, and there are the causes which affect men. Let's start with the ladies, because ladies first.
Okay, yes.
So when it comes to ladies, I'm not going to put them in any particular order, but I'll start with the first one, which is very important, and that is age. The age of a patient, the age of the lady. Why is it, and what age are we looking at? We're looking at 35 years and above. And this is simply because, unlike men, women, you come let me put it that way, self-contained. What do I mean by that? You are born with a set number of eggs, and when you start your periods, which these days is on average about from 13, 14, 15 years, and then every month you have that flow, you have a period, you lose about between 500 to 800 eggs in every flow.
Okay.
It's worse for me.
Well, that's scary.
It is.
Yes.
Now, what happens when you get to 35, maybe 40 years, for example? You have been having these periods every month, and every month you've been losing, let's work with 800 eggs on average. So you start your periods at 13. By the time you get to 35, you are 22 years of having periods, and you're not pregnant. So imagine 800 eggs per month, multiplied by 1 year, multiplied by 22 years. So you find that number of eggs that you are born with has actually done what? Has actually diminished. So the ovarian reserve has actually reduced. And that is one of the biggest problems that we are having when it comes to age. We saw in Europe, where I used to work in the UK, very many patients, of course, theirs is a little bit different in that you go to school, you start training, you want to get to a professional, you want to get the pinnacle of your profession, and once you've reached there is when you realize, Allah, sina mtoto.
Exactly.
So now they start now looking for them. So age there is a big problem. It is actually catching up with us here at the moment as well. Actually, 2 days ago, I was talking with my students at the University of Nairobi. I was telling them, look, medical students, by the time you finish medical school, you're about 24, maybe 25. They go for what you call internship for 1 year. Then after that, they have to work a bit before they come back for a master's degree. And by the time they finish their master's degree, they're about 34, 35. And they will not start working straight away as consultants. They need to work for about 2 years before they get that consultant certificate. And now they can start. You've spent so much time studying, which is a fantastic thing. And then you realize, Allah, by the time I get here now, I'm a consultant. And if those guys who are hitting on me in college, nikafikiria hawawezi kunisaidia, and they moved on, they went to law school, they got ladies, they are married. When you realize what is happening, unakuta wewe umebakia peke yako. So age is a factor. So the number of eggs has reduced. In women, it doesn't affect men as much, because if you get a gentleman who is 70, for example, and can actually be able to have an erection, and gets a young lady at the right time, and as a kampatia mimba. Now, the issue that we are having with men, which has started appearing with the age, is now the issue of, poor quality sperm, and this can affect the baby later on. But that is a sort of a secondary issue, not a primary issue, as age is for women. So age is a factor. Number 2, blocked tubes. We see 80 or 85% of the patients that I see have a problem with blocked tubes. Either they have one side is blocked, or both sides are blocked. They can have some fluid in the tubes as well, and so on and so forth.
What causes that?
What causes it is basically most of the time sexually transmitted diseases. So if you have many partners, Or conversely, you may have one partner. You decide this is the gentleman that I'm going to live with, or this is the one I'm going to have, intercourse with. But he may be having other partners out there. So whatever he gets from out there, anakuletea. Something again which we need to talk about here, which is very, very serious. The other day, I was in theater and we did what is called a laparoscopy. We had 3 patients, young patients, 25 to 30 years. Obviously, all of them were trying to have a baby, and it was not possible. When we put a camera inside the abdomen, there are some symptoms which are typical of an infection called chlamydia. And all 3 of them had chlamydia infection, but they didn't have any symptoms at all. The only thing that actually brought them to KNH to be treated were blocked tubes. So chlamydia is a big problem, and the worst thing is that there are no symptoms. There's no pain, you don't feel anything, but again, it's sexually transmitted. Other things that can cause blocked tubes are, for example, gonorrhea, and also syphilis. This used to be very, very common. They are less common these days, but they are still there. So sexually transmitted diseases. You have to talk about HIV, which is also a big, big burden in this part of the world. And not to forget about things like human papillomavirus, HPV as well, and so on and so on. There are herpes as well, and etc., etc. So these are some of the things that women have a challenge with when it comes to infertility. The other thing is fibroids. And fibroids is basically a growth or growths on the womb. Now, these growths can be outside the womb, they can be in the muscle of the womb, or they can be inside what you call the endometrium or the cavity of the womb where the baby normally grows. The bigger challenge is where the location. So, for example, if you have half a centimeter fibroid, which is growing in the cavity where the baby is supposed to implant, and an embryo that is the beginning of a baby is actually, you can't see it with your naked eyes, even under microscope is very tiny. We have been created in a fantastic way. I think I should take you one day to the lab so that you can see how.
Yes, I would really love to. I would be surprised, but it will be interesting.
Because you see, out of those tiny structures, we are who we are. They determine everything that we are. The height, the color of the skin, eyes. But when you see it in the lab, you can't believe it. So anyway, once we have transferred this embryo into the womb, and there was that half a centimeter fibroid which is in the cavity, for the embryo, this half a centimeter fibroid is like Mount Everest.
Okay.
It cannot circumvent it in any way. So you find implantation becomes difficult. So fibroids. Sometimes you have women who have very big fibroids. 40 to 60% of ladies of African origin will have fibroids, a fibroid or fibroids in their reproductive period. A colleague of mine wrote a paper, and the title was, "Mine is 140, what is yours?" So basically what he was saying is that he had removed 140 fibroids from a patient.
140.
140.
And what causes these fibroids, if I may ask?
Fibroids are basically a growth from the smooth muscle, what you call the smooth muscle of the womb. And what causes them is basically they feed on a hormone, the female hormone, which makes women be women, that is estrogen. So that is what feeds them. But now the question is, do African women or women of African origin either have a high level of estrogen, or the receptors, what you call receptors where these hormones work, are they very many in the womb in African women? That one we are not very clear about. All right, so that can be a challenge. So fibroids can be a problem. So age, talked about blocked tubes, talked about fibroids. We have something called endometriosis. Endometriosis is also a big, big issue, an enigmatic disease. I think one of your colleagues wrote something about it in the newspaper not too long ago. And about 15% of the women who come because of infertility, especially younger women. A colleague of mine had a very interesting case of a young lady, 16, maybe 17 years, who had serious endometriosis, and she would bleed from the hand during the periods. She would bleed, in the joints. from the ears, something which is unprecedented and not very common. So endometriosis is a problem. We also have a problem with what is called polycystic ovaries, what we call polycystic ovarian syndrome. Now, this again affects about 10%, 10 to about 15% of the young ladies who come to see specialists. The problem here again is a syndrome, where it's a syndrome that not all the patients who are affected will have the same symptoms. Some will have some of these symptoms and will not have others. But one of the very common symptoms is irregular periods. The periods are very irregular, may skip maybe 60 days, they may skip even for a year. I had a patient who would have a period every 2 years, for example.
I want to say they're lucky, but equally they're not.
I know. Yeah, but you see, I mean, they don't have a period, but very difficult for them to get pregnant because you can't plan when you don't have a period like that. Apart from that, they have other issues. They have other issues with bloating. They have issues with sugar levels. They have issues with low libido, etc. Again, not all of them. There are some who are completely normal, have periods, regular periods, get pregnant. So when we do a scan is when we find out that, they are polycystic ovaries. And then the other thing is, which is also one of the symptoms which is quite common, is that they have some hair where women generally don't have hair. So they'll have around the upper lip, the chin, around the nipples, the abdomen, and so on. Yeah. So a polycystic ovarian syndrome. We have other issues. Hormones, for example. Irregular hormones. For example, there is a very interesting and very important gland which is right here called the thyroid gland. It produces what is called thyroid stimulating hormone. It's like a manager of other hormones in the body. So if that hormone is elevated or is not elevated or very low, it will affect the way the body behaves. And it will affect the reproduction, system as well. When we talk about what we call structural deformities, that these women are born that way. There are some who are born with a very tiny womb, for example. Others are born with a womb which is divided into two completely, 2 wombs, 2 cervixes, and sometimes even 2 vaginas at the same time. Others are born without a womb, for example, but they have ovaries. So we have also these structural anomalies which they are born with. Now, apart from that, there are issues about our lifestyles. I think you mentioned about it, you asked about it. Is it something that we eat? Yes, it has. What we eat, how we eat it is also a problem. For example, there are some societies whereby once you get married, they expect you to put on weight nicely in the right places and so on. They also expect the man to put on weight as well. But now the man, where we put on our weight? In the abdomen.
Tumbo. Societal pressures. Yes.
He has a public opinion. So it's a good public opinion. Now, the issue comes when that public opinion can actually get in the way of what we are supposed to be doing. So you have a good public opinion and the lady is also well endowed. Sasa kufika mahali ambapo mzee anataka kufika inakuwa ni shida. So it becomes a challenge. The foods that we eat, we are slowly starting to sort of imitate what the West eats. A lot of refined foods, number one. Number two, we are not doing enough exercise, not unlike before, whereby we were doing a lot of walking from point A to point B. These days, you jump into a car, or number 3, from point A to point B, especially in the so-called middle class to so-called high class. Then we also have issues with intercourse. There are ladies who don't have regular intercourse. There's a time we went to the coast and we had a camp there, and I would say about 30% of the women that we saw actually were not living with their husbands. Their husbands were living outside, working. So by the time they come for annual leave, you may find that these ladies are not in that part of the cycle where they can actually be able to get pregnant. And the guys have to go back. So you find the man is here for 3, maybe 4 weeks. But then if the lady is not in that part of the cycle, haiwezi kushika. Now, the other issues we have is abortion. Abortion or post-abortion problems. Abortion is a big issue. I think we'll need another session to talk just about about
That's
abortion.
a very controversial one.
It is quite controversial, but it is here with us, and it is we have to look at it now. The women who have, who sort of have illegal abortions, somewhere which is done by people who are not qualified, they end up getting complications, infections, and so on and so forth. Now, these infections sometimes, or not sometimes, most of the time, will affect the organs in the pelvis, that is the tubes. Sometimes they may even perforate the uterus, etc., etc. And this will have consequences later on, and so on. Now, you may also have issues. Say, for example, you've gone for a procedure, and then that procedure is done, but then it's done too well. Let me put that in quotes. For example, we are removing stuff from the womb, and then we do it so vigorously. What happens later on is that we may have what is called Asherman syndrome, whereby this woman literally has a very, very little flow or no flow at all, because that lining has been completely removed, and then there is a growth, or there are growths inside. So you may put a camera inside there, and it looks like a forest. So there is no embryo, no baby is going to implant there. Okay. So those are women. For the men, the men will also have issues. Where we talked about blocked tubes in ladies. Men can also have blocked tubes, and the reasons are the same. Sexually transmitted diseases. So you find that where the sperm passes through gets blocked. So what comes out, that doesn't mean that these men will not have an ejaculation. They will have an ejaculation. But what will come out is just fluid from the prostate gland.
Not the sperm.
And not the sperm. Okay. Because the way the avenues, the pipes where the sperms are supposed to pass through are blocked, and there is no sperm. You may have what is called undescended testicles, whereby the testicles normally, once baby boy is in the mother's womb, once he's born, the testicles are supposed to descend and get into the scrotum. You may have issues with twisted testicles, and that twisted testicles actually stops blood flowing into the testicles, and that will actually kill them, as it were, and they have to be removed, unfortunately.
So what happens when, for example, there's no flow of blood and they need to be removed? Because I think that's what you said.
Yes, if the testicles are twisted and there's no flow of blood to the testicles, unfortunately they die. And if they die, they have to be removed, unfortunately.
Can they be replaced? No.
Replace them, unfortunately. There was a case some time ago of a young man who went somewhere in one of the hospitals or clinics or some of these places, and was there from Thursday to Saturday. Went there with both twisted testicles. Unfortunately, whoever saw that young man was not a doctor, because they kept him there for 3 days. And by the time that young man was brought to KNH, my urologist colleagues unfortunately had to remove both the testicles because they were what you call gangrenous. They had died, and then they had sort of got infected, so they had to be removed. You can also have hormone issues in men. For example, there's a hormone called FSH, follicle stimulating hormone, another one called LH. They have to work in tandem, plus testosterone and so on, so that there is production of sperm. So if you have the FSH is elevated, the LH is also elevated, most of the time what happens is that there is no production of sperm at all. So there is a disease called cystic fibrosis, and it's a genetic disease. Fortunately, it doesn't occur a lot in this part of the world. It affects quite a large population of people of Jewish origin, because I think of the intermarriage and passing on, their genes to their that gene to their children. And in this disease, where we have organs which have, let me call them pipes. For example, you have a windpipe, and you have those pipes that pass, pass sperm and so on. They produce an extra amount of thick mucus, and this stops them from working the way they're supposed to be working. So in such a case, production of sperm is not there as well. You have issues with tumors, for example. growths. There can be growths in the brain, in the spinal cord and so on. Accidents as well, accidents whereby somebody is paralyzed and cannot be able to, to ejaculate and so on and so on. Let's not talk about smoking, for example. Smoking is a big problem. Cigarette smoke has about 2,000 to 3,000 chemicals, and some of those actually go and affect the production of sperm. The other thing is consumption of alcohol. They will tell you if you drink 1 or 2 beers, well, it's not so bad. A glass or 2 of wine is not so bad. But the more we drink, or for those ones who drink, the more alcohol you take, the more inebriated you become, the less effective you're going to be in bedroom issues as well. So all these things, and then apart from that, most of the time when you are sloshed, you'll tend to make decisions which are not sensible. You'll have, extramarital affairs. You may have sex with people you don't know. You may have, and the consequences of that is that you may have infections, which will later on downstream will have an effect.
Okay. How do they get treated?
Taking the medical history, there are some certain tests which I would like them to do. For the gentleman, it's a very straightforward problem. Not problem really, but a straightforward test, and that is a sperm test. Okay. Most of the time, 99.9% of the time, it's done by masturbation, even though in other places they have a special condom which they can use. We don't have it locally available at the moment. For the ladies, we have several tests. We want to check whether their tubes are okay by doing what is called an HSG, hysterosalpingogram, where we put in a little bit of contrast, and that contrast is supposed to go through the womb and flow out if everything is okay. And they have, X-ray pictures taken. And we can actually now look at those pictures and see whether there's a problem, whether there's a blockage, etc. We need to do a hormone test for them. And which hormones are we looking at? We're looking at what you call AMH, which tells us about their ovarian reserve. Okay. We look at what is called TSH. You remember I mentioned the thyroid gland, and then what is called prolactin. Those are very basic. If there is a need, we can do some other tests. We also need to do a scan, and here what I normally do is a transvaginal scan, whereby I want to look at the ovaries and I also want to look at the womb. I want to look at the ovaries because there is something called AFC, antral follicle count, so I can have an idea about the fertility of this lady. The higher the antral follicle count, the higher the ovarian reserve, and the higher the chances of her to get pregnant.
When you talk about infertility in general and everything that you've talked about, there's so much that even I didn't know that I'm learning now. How best, even going forward and creating awareness, especially for this month, how best can we get that message across to Kenyans that, it's fine to have infertility issues. It's normal, not for people to take it as, I've been cast or, coming from an African culture and everything.
So you brought out a very interesting aspect of infertility, and that is the sociological aspect of infertility, how we relate in our society, wherever we come from, our different tribes, our different beliefs, traditions about infertility, umerogwa, mama mkwe amekufunga, sijui nini, and so on and so forth. These are things which are myths. Myths kwamba umefungwa mahali, it is not true. And then the other thing is that what we don't understand, we actually sort of put it to neurogi. Yes. Something which cannot handle. So tuyeke huko, and that's it. Because essentially we are able to diagnose practically everything about infertility. That is one thing. The stigma that comes with it, you mentioned that stigma. There are different names, different titles from our different, societies where we come from. The Luos call the women Luer or something like that. Yeah. Watu wa coast wanaita ni tasa, mwanamke tasa ama mgumba. The Kisis call them riteba, and so on and so forth. And it is a title when you are given, it's sort of you are not part of us because you don't have a child. And then the other thing is that the way we have been socialized also comes in. Ashley, if you have a baby, utaitwa mama fulani. So when you go out to your colleagues, your friends, wanasema enda uambie mama fulani kwamba 1, 2, 3. Enda uniambie. So what happens when you don't have that baby? The man is also the same thing. Baba fulani, baba so and so. When my daughter, When we get to her friends, her age mates, I'm called Baba Shishi, because when we go to my son's age mates, I'm called Baba Mogaka, And so what happens when you don't have it? Does that mean you are less of a human being? Does that mean that you are not, capable of doing other things in society? No, we are capable of doing that. And I think that is what affects especially men. And men, we don't talk about our problems. We'll talk about politics, we talk about football, whether it is Chelsea or Man City or Arsenal or whatever it is. We talk about finance, we talk about whether it is Azimio or whether it is UDA or whatever it is. But personal issues where I can get help, never. I think we need to talk about, you asked about what can we do so that we bring out this awareness. Actually, I'm very grateful for you to invite me to the studio to talk about this, because it's a big problem. You have a wide, reach with the TV station. So talking about this is one of the things. Ladies, convince your men to come with you to actually to the doctor. There's a lot of information out there in the internet, which is easily accessible. The only problem is that some of that information may not be very accurate, because it's written by all and sundry. So sometimes it may not be exactly what you need. So if they get that information, they can actually come and say, look, this is what I read. Is it really what it is, or is there something else? The other avenues which can be used, for example, churches. Most of us attend church, whether it is Saturday, Sunday, or even Friday for the Muslims. These are places, avenues which can be used so that they can be this information can be availed. Apart from that, COGS, that is the Kenyan Obstetrical and Gynecological Society, from where I see it as the president, we are doing quite a bit. For example, we are doing what we are doing today. In June, we have planned quite a number of activities on the radio as well. We are going to write some articles in the newspapers as well, such that we try and reach all and sundry, such that they know that if there is such a problem, don't die with it. Don't sit with it. Bring it out. There is help.
Thank you very much, Dr. Kirekio Manwa, President of COGS, and of course, the fertility expert at Frontline Medical Consultants. And I hope you've learned a thing or two, and you can pass the message to your friends, your family, and anyone who needs it. Thank you for watching Morning Prime. I'm Ashley Mazuri.